So I'm Dr. Anroop. I'm professor in Department of Oral and Maxillary Surgery. I'll be dealing with the topic temporomandibular joint ankylosis. So, so these are the expected questions in temporomandibular joint ankylosis. We've got short notes on ankylosis in children and Kaban's protocol. So ankylosis is defined as development of a significant or a complete limitation of movement of the temporomandibular joint by bone or fibrous tissue. So trismus, it is a condition where there is muscle spasm and there is contraction of or there is spasm of the muscles which prevents the opening of the mouth. The pseudoankylosis refers to a joint mobility with fibrous adhesions where within the joint structure. And a true ankylosis is a condition where there is fusion of the bony surface of the joint. So coming to the anatomy, temporomandibular joint anatomy consists of mandible suspended from temporal bone via ligaments and muscles. A true synovial joint capable of gliding, hinging, and sliding, and rotation movements. And the mandible and temporal bone it is separated by a meniscus or rather a disc. So etiology of ankylosis is trauma, infection, inflammation, systemic diseases, rare causes, and others. In trauma, congenital birth, hemarthrosis, and condylar fracture, or glenoid fossa fracture, these can also lead to a temporomandibular joint ankylosis. Infections like otitis media, mastocytitis, parotitis, tonsillitis, furuncles, abscess around the joints, osteomyelitis, and actinomycosis, these can also may lead to temporomandibular joint ankylosis. And inflammatory causes are rheumatoid arthritis, septic arthritis. Systemic diseases are scarlet fever, typhoid, gonococcal arthritis, ankylosing spondylitis. All these things are systemic causes which can cause temporomandibular joint ankylosis. And under rare causes, polyarthritis and measles. And other causes, you got bifid condyle, prolonged trismus, prolonged immobilization, and even burns can cause temporomandibular joint ankylosis. So under the classification, we have true ankylosis and false ankylosis. There is fibrous or bony ankylosis based on location, extra-articular and intra-articular. Classification based on extrafusion is partial and complete, and based on side involvement, unilateral and bilateral. Casagian's classification, there is true ankylosis, which is fibrous or bony, and false ankylosis. So this is our classification based on OPG. You need to take an OPG and study the OPG to find out which type of classification it comes under. And it is it has been put forward by Shabney in the year 1986. So in type 1, there is flattening or deformity of the condyle with little joint space seen on the radiograph. In type 2, bony fusion of the outer edges of the articular surface, but no fusion within the deeper areas of the joint. And in type 3, there is a bridge of bone between the ramus of the mandible and the zygomatic arch. And in type 4, the entire joint is replaced by mass of bone. So these inferences are got from OPG. And in clinical features, you've got unilateral and bilateral ankylosis. So in unilateral, there is obvious facial asymmetry, deviation of the mandible and chin on the affected side. Chin is receded with hyperplastic mandible on the affected side, roundness or fullness of the face on the affected side, appearance of flattening or elongation on the unaffected side. The lower part of the mandible on the affected side has a concavity of well-defined antigonial notches present. And these are the other clinical findings. With unilateral ankylosis, some amount of oral opening may be possible. Interincisal opening may vary depending upon the fibrous or bony ankylosis. Frostbite may be seen. In class 2 malocclusions is typically seen. Condylar movement is absent on the affected side. So this is an example where there is unilateral ankylosis on the right side of the patient, and where there is fullness of the face on the right side and bony elongation or the proper growth of the mandible is seen on the left side. Okay, so in this case, the ankylosis is on the right side of the face. Bilateral ankylosis, it is a typical bird face appearance with symmetrical mandibular micrognathia. Neck chin angle is low or all completely absent. Antigonal notch is well defined. Class 2 malocclusion. Upper incisors are often protrusive with anterior open bite and minimal mouth opening with 5 millimeter or nil, with multiple caries tooth and bad periodontal ligament, periodontal health. So this is a typical bird face appearance in a bilateral ankylosis case, and you can appreciate the bird face. And coming to the history, clinical findings and radiographic findings. So imaging, we have to take an OPG that shows both the joints with ankylosis. If you're not satisfied with OPG, you can always go for lateral oblique view of the mandible, and lateral cephalogram will also give a idea about the joint space. PA view can also be taken. If you're not satisfied with conventional X-rays, you can always go for CT scans and MRIs. So these are the picture of the CT scans where there is, you can see, appreciate bony deposition in the condylar area. In the OPG also there is bony deposition, and in a sagittal section of the CT, you can appreciate the bony deposition on the condylar area. So coming to the goals of the surgery, you have to release the ankylotic mass and create a gap to mobilize the joint, to create a functional joint, to reconstruct the joint and restore the vertical height of the ramus, to prevent recurrence and to improve aesthetics. So Kaban in 1980 has laid down some protocols for the management of temporomandibular joint ankylosis. This is a very important and a short thing which you need to write on the temporomandibular joint ankylosis essay. So he has postulated aggressive resection, ipsilateral cornoidectomy, contralateral cornoidectomy, lining of temporomandibular joint with fascia, reconstruction of the ramus of the costochondral graft, rigid fixation of the graft, and early mobilization, and aggressive physiotherapy. And coming to surgical procedures, you need to have condylectomy, gap arthroplasty, and interpositional gap arthroplasty. So we'll resume the rest of the class later. Thank you.